Intestinal obstruction can be partial or complete, and they're classified as mechanical or non-mechanical. In mechanical obstruction, the bowel is physically blocked by problems outside of the intestine, so such as adhesions, which is just scar tissue from previous surgeries or pathology. The blockage can be in the bowel wall, so things such as Crohn's disease, or in the intestinal lumen, so like tumors. Non-mechanical obstruction is also known as paralytic ileus or adynamic ileus. It does not involve a physical obstruction in or outside of the intestine. Instead, peristalsis is decreased or absent as a result of a neuromuscular disturbance, resulting in a slowing of the movement or a backup of the intestinal contents. A lot of times a paralytic ileus is caused from abdominal surgeries because the bowel kind of goes into a shock after being manipulated, and it kind of shuts down and it leads to a paralytic ileus. Another reason is a volvulus, so this is a twisting of the intestines. This would be a mechanical obstruction. So to summarize, mechanical is a physical blockage, in adhesions, volvulus, intussusception, incarcerated hernias, tumors, strictures, or impacted feces are all examples of mechanical obstructions. And then non-mechanical is can be from lack of blood supply due to a clot or narrowed arteries, a neuromuscular problem such as paralysis or paralytic ileus after surgery. Those are examples of non-mechanical obstructions. Signs and symptoms is repeated vomiting. So this means that the emesis may appear green, which is bile, indicating that the client has repeatedly vomited prior, because they're not vomiting any food or anything that was left in the stomach. If they're just vomiting bile, like green liquid, that means that they've been repeatedly vomiting. They can also vomit fecal matter if the obstruction is severe enough and backed up enough, which would be obvious. It smells like fecal matter and it's brown and it looks like feces. They will either have decreased or absent bowel sounds, or they will have, if it's a partial obstruction, they will have hyperactive bowel sounds because the bowels are trying to move that stool around the obstruction. They might have severe abdominal pain, cramping, nausea, distension, tenderness, dehydration. They may have diarrhea or ribbon-like stool if a partial obstruction is present, because again the bowels are pushing around that obstruction and it causes either diarrhea or ribbon-like stool. All of these signs and symptoms lead to a loss of fluid and electrolytes, can lead to perforation of the bowel or strangulation of the intestines. And the severity of symptoms depends on the site of obstruction and the degree of obstruction. Pressure increases, proximal intestines dilate, smooth muscle becomes atonic, peristalsis ceases, fluid shifts into the intestinal lumen, decreased blood flow to the intestinal tissue, and then gas collects from air swallowing, and then an action of bacteria. So all of those signs and symptoms are from this pathophysiology. Diagnosis is that KUB abdominal x-ray, a CAT scan, and then labs may show electrolyte imbalances and dehydration. So treatment of patients with intestinal obstructions, the first step is usually they're going to be NPO, NG, nasogastric tube, and they're going to have intermittent suction. IVs with hydration, pain management, intake and output, which is usually only going to be output because they're going to be NPO, but you're going to account for their intake with the IV fluids. If it's not better after 24 hours, they're usually going in with surgery with that exploratory laparotomy to repair the obstruction. So they'll remove adhesions, take tumors out, widen the intestines, and things like that. They may have to do a colostomy, which can be permanent or temporary depending on the cause of the obstruction. So if it's a tumor from cancer, or if the adhesions are severe, or if they've had that volvulus, that twisting of the bowel, and the bowel died, they're going to have to remove part of the bowel, and they may have a colostomy while they heal, or it may be permanent if they have to remove a large amount of the bowel. But there is a difference between small bowel obstructions and large bowel obstructions. So most often they are small bowel obstructions that you'll see, and these are the ones that we use the NG to suction. If it's a large bowel obstruction, the NG really doesn't do much. So those we usually use enemas to treat. Complications of obstruction include peritonitis, especially if the bowel has perforated. Strangulation of the bowel, which leads to bowel death, sepsis, and hypovolemic shock. So like I said before, small bowel obstructions will usually always have the NG to intermittent suction for at least 24 hours, maybe a few days prior to any surgery is done. This is to decompress the bowel and to drain that fluid and air from the bowel, the small bowel. The patient also may return from surgery with an NG to let the bowel heal a little bit more. NG tube care. So you're going to assess the nasal skin for breakdown. They're going to need frequent oral care, assess placement, patency, and characteristics of the output at least every 4 hours. So that's making sure for placement that you're looking at the number at the nair and making sure that it hasn't moved at least every 4 hours. Can do it more often. Patency, making sure that it's still draining. If the patient becomes nauseous, usually that means that the NG is not doing its job. It might be misplaced, it might be obstructed, it might be up against the stomach wall, so you may need to move the NG around if they're having nausea, because usually the NG suctioning takes away that nausea. So if they're having nausea, that means there's something wrong. And then characteristics of the output, documenting the amount, the color, the consistency, and things like that. So what type of acid-base imbalance might the nurse see if the patient is on NG suctioning? I know you guys can't answer me, so it's metabolic alkalosis, because remember you're taking all that acid out of the stomach, so they're going to be alkaline now. Priority nursing post-op care. So it's standard post-op care, coughing and deep breathing with splinting, NG maintenance until they're passing gas. So asking your patient, every 4 hours that you're going in and maintaining the NG, asking them if they're passing gas, if they feel like they need to have a bowel movement, those type of questions. They might have an abdominal binder. Prevent infection, especially at the incision site. Prevent pneumonia by getting them up and moving, coughing and deep breathing, preventing DVTs, again, getting them up and moving, putting the TED hose or SCDs on them. Incisional care, general nursing care of an intestinal obstruction is assessing the bowel sounds frequently, and you need to do this with the NG suction off. So make sure you're turning off the suction and you're waiting, maybe 5 minutes, 5 minutes until you can check for those bowel sounds, because you're going to hear the NG suction rather than bowel sounds. Ask them about passing gas and bowel movements. Passing gas is that sign that the obstruction is clearing. Monitor their eyes and O's and electrolytes and IV hydration. Advance their diet as tolerated when the doctor orders it. assess for tolerance of that diet at each step. So if they become nauseous after clear liquids, you know that they can advance to the next diet level. Pain management is directed towards non-opioids because they will slow down the bowel and can cause another obstruction. So they usually give them something that's non-narcotic. Assess urine output, give antiemetics, reposition the patient frequently or ambulate them frequently if able, because this increases peristalsis and helps the bowels move. And then administer enemas as ordered. So prevention is big with intestinal obstructions, especially if they've had an abdominal surgery. So teaching them a high fiber diet, increasing fluids, increasing activity, add Metamucil, which is a bulk forming powder, to 1 meal a day, and use natural laxatives like prune juice or warm liquids to prevent dependence on commercial laxatives. It is very important to get your patient moving after any surgery to prevent paralytic ileus, which is the most common cause of the bowel obstructions that we see. Intussusception is a telescoping of the bowel into itself. The cause is mainly unknown. It mostly affects children 3 months to 5 years of age, but it can occur in adulthood. Signs and symptoms include current jelly-like stools. This is the hallmark sign and symptom, are the current jelly-like stools. Sudden abdominal pain. The patient will draw their knees up, vomiting, listlessness, a sausage-shaped mass in the right upper quadrant, distended abdomen, very tender. It's diagnosed by a barium enema. And treatment, if it's left untreated, it can be fatal in 2 to 5 days. It can be treated simply with a barium enema or an air enema. It may require surgery if the less invasive options fail. Priority nursing care is comforting the parents and the child. They're most likely going to need IV hydration and electrolytes. That's standard post-op care if they've had surgery. They may have a recurrence, so teach the parents to bring the child in immediately if they have repeat signs and symptoms. Gastroenteritis is the stomach flu. It is an increase in the frequency and water content of stools and or vomiting as a result of inflammation of the mucous membranes of the stomach and intestinal tract. It affects mainly the small bowel and can be caused by either viral or bacterial infections, which have similar manifestations. So causes the viral rotavirus and other organisms. It's often in children younger than 2, accounts for about 50% of hospitalizations with diarrhea and dehydration. 80% occur in wintertime, and it's a frequent nosocomial infection. Signs and symptoms is sudden vomiting and diarrhea, abdominal cramping, dehydration, weight loss, fever, recent travel or contact with contaminated foods. Diagnosis is a stool culture and sensitivity. So this will find bacterial or viral causes such as the rotavirus and C. diff. They might have an ova and parasite stool done to determine if it's from a parasite. They might have a urinalysis done to determine the degree of dehydration. So if it's if it has a high specific gravity, this is caused from dehydration. They might have an H&H done because this can also determine dehydration, and it would be high in dehydration. Their electrolytes will be low due to vomiting and diarrhea. And they might look at the creatinine and BUN, which are kidney function labs, and can be high in dehydration. And the white blood cells may be elevated due to the bacterial or viral causes. Management is IV hydration, NPO if they're vomiting, and antibiotics if it's bacterial. Otherwise, it's simply just comfort care until the inflammation goes down and their symptoms are better. Priority nursing care, number one goal is rehydration. Be sure that the client is getting plenty of fluids. Avoid milk, caffeine, soda, coffee, tea, since these things increase the intestinal motility. If you have a kid with gastroenteritis, you're going to give them Pedialyte or breast milk and formula as much as tolerated. Adults may have IV hydration or Gatorade. Strict I&O. For infants, you're going to weigh their diapers because this accounts for a more accurate intake and output. So weighing the diapers of infants is a more accurate way to determine their intake and output. Monitor labs, especially electrolytes. Teach to decrease the spread with hand washing and disinfecting their bathrooms. You're going to obtain cultures as soon as they're able to give you one. And you're not going to give them antidiarrheals because you want the patient to evacuate all of the contaminated stool. So no antidiarrheals. They can have antiemetics, however, if they need it, if they're frequently vomiting. Irritable bowel syndrome, or IBS, is a functional GI disorder that causes chronic or recurrent diarrhea mixed with constipation and or abdominal pain and bloating. It's sometimes referred to as a spastic colon, a mucus colon, or a nervous colon. Contributing factors is coarse, highly seasoned food, panic attacks and or stress, a history of child sexual abuse, and it can also be due to genetics or hormones. Signs and symptoms, there's different types of IBS. They can have alternating constipation and diarrhea, or they can just have constipation, or they can just have diarrhea. So there's really 3 different types. Other signs and symptoms is cramping, gas, a feeling of incomplete emptying. Weight loss is not usual. They may have mucus in their stool as well. Diagnosis occurs by exclusion, so they've found no structural or pathological abnormality. Sometimes it's diagnosed solely by symptoms. Labs are not usually significant and not diagnostic, but they may have labs and other tests done to rule out more serious issues. Treatment is based off of symptoms and self-management is the goal. So diet includes high fiber, at least 30 to 40 grams per day. Bulk forming meds like Metamucil, anticholinergics, which is Bentyl, and this relieves cramping. Milk of magnesia for constipation. Lomotil or Imodium for diarrhea. Anti-anxiety or antidepressants if it's caused from stress or panic attacks. Linzess is a new medication for constipation. It stimulates the intestinal receptors to increase fluid in the bowel and to increase transit time. But again, this med would be for IBS patients that have problems with constipation and not diarrhea. Nursing responsibilities is teaching to increase their fluid intake to 8 to 10 glasses per day. And that's for either or, that's if they're constipated or having diarrhea. Listening and taking history of the client. Tell the patient to keep a daily log of their bowel movements, along with the stress, anxiety, pain, and diet. And then figuring out what their triggers are and teaching them to avoid those triggers. Moving on to chronic inflammatory bowel diseases, we're starting with ulcerative colitis. There's a good table on page 77 of your notes that compares the bowel diseases. So ulcerative colitis is a widespread inflammation of the mucosal and submucosal layers of the rectum and rectosigmoid most commonly. It can spread to the cecum in a continuous pattern. So it spreads continuously, not sporadically. It will lead to permanent damage that causes scarring. It's 2 times more common than Crohn's disease, and the age of onset is young to middle-aged adults. Causes, some are unknown, some are caused from genetics, and others are caused by autoimmune issues. Ulcerations begin in the rectosigmoid colon. The ulcers may perforate, mucosal edema can happen, and then scar tissue will eventually occur. Signs and symptoms is diarrhea with pus or blood. Capillaries in their intestines become fragile and bleed, which leads to the blood in the stool. They have 15 to 20 bowel movements per day if it's severe, and they have 2 to 5 bowel movements if it's mild to moderate. They can have leakage of stool due to scarring that lessens the urge to defecate, and they'll have loss of electrolytes and dehydration, especially if they're having 15 to 20 bowel movements per day. Complications is dehydration, electrolyte imbalances, which can lead to arrhythmias. So you need to think about the heart with patients with UC, especially if they're having 20 bowel movements a day, looking at their electrolytes, looking at their tele, making sure that they're not having arrhythmias from a loss of those electrolytes. Other complications is perforation of the colon, leading to peritonitis and sepsis. They may have malignant polyps form, toxic megacolon, and bowel obstructions. Diagnosis is done by colonoscopy, which is the most diagnostic for ulcerative colitis. Treatment includes sulfasalazine is the drug of choice. It decreases inflammation, and you need to teach to take it with meals and increase fluids and folic acid, and then also warn them that their urine may turn orange. There's also non-sulfa drugs, which is dipentum, PO or mesalamine by retention enema. These are other anti-inflammatories. They also may have corticosteroids, immunosuppressive drugs like cyclosporine. Again, these are just more anti-inflammatories. And then they usually take an anti-diarrheal like Imodium. Diet therapy is not a major factor in UC, but some patients find certain foods more irritating than others. So tell them to avoid those foods that increase their symptoms. UC patients without aggravating foods do not really need to follow a specific diet besides increasing their fluids and maybe electrolytes. In your notes, I know it says no spicy foods, milk products, or irritating foods, and low residue. Just cross that off. It's an outdated. It's outdated. They're now saying that there's not any certain foods that really cause problems unless the patient is saying, yes, I've eaten this and it causes me to have more bowel movements. So, but in general, that list there, you can just cross off for a general aspect of ulcerative colitis. A healthy balanced diet high in protein and high calories is sufficient for a normal UC patient. TPN may be needed in acute exacerbations that require hospitalization. So if they're having that severe exacerbation where they're having more than 20 bowel movements a day, they may need to be hospitalized, put on a cardiac monitor. They might have TPN because they're going to be NPO so that their bowel can rest. Also teach them stress control. There's some aspect of stress and anxiety that goes along with UC that can increase their symptoms. So teach them stress control and relaxation techniques. Surgical intervention is a colon resection, which will probably lead to an ileostomy, and they may also have an ileoanal anastomosis, so that's removal of the colon and rectum, but leaving the anus and attaching that to the small intestine, attaching that to the healthy bowel. So they'll take out the diseased colon and attach the small intestine to the anus. They may have a proctocolectomy, which is removal of the anus, rectum, and colon, and they'll have a permanent ileostomy with that. They may have a Koch pouch, which is the same as I just talked about, but a pouch is formed from the ileum. So pre-op care, they're going to need bowel prep, a bland to clear liquid diet, and antibiotics. And then post-op care, it depends on the type of surgery. So if they've had an ileostomy formed, if that ileostomy is temporary or permanent, if they had a proctocolectomy, you're going to be looking at the anus, looking at incisions. So it depends on the type of surgery for your post-op care. Priority nursing care in general is realizing that these patients frequently go into remissions and exacerbations, so they need help with coping due to their diagnosis of a chronic illness. It's very overwhelming because they're going to frequently go in and out of these exacerbations, and they need help with decreasing their stress and figuring out ways to cope and deal with this chronic illness. Rehydration and nutrition in acute episodes is usually done with IV fluids or TPN. Teach them about their meds and how to avoid stress and aggravating substances. Many of the meds that I talked about are immunosuppressants, so caution them to stay out of crowded areas and stay away from those with acute infectious illnesses. And then teach about signs and symptoms of complications, so peritonitis, perforation, sepsis, bowel obstructions, arrhythmias, dehydration. Teach them about all those signs and symptoms so that they know when something more serious is happening. Crohn's disease, it's also called regional enteritis, is an inflammatory disease of the small intestine most often, but it can affect the colon or both. It can affect the GI tract from the mouth to the anus, but it most commonly affects the terminal ileum. Inflammation causes the thickened bowel wall with strictures and deep ulcerations that have a cobblestone appearance, as you can see in the picture. It does not progress in a continuous fashion like ulcerative colitis does. It usually affects one segment of bowel, multiple segments, and it alternates with normal tissue. So it's not a continuous spread like in UC. It alternates with diseased bowel and healthy bowel. But it does affect the entire thickness of the bowel, and it leads to scarring and fibrosis. The age at onset is young, like 15 to 30 years of age. The causes are, some are unknown, there is a genetic component, and some are autoimmune. Signs and symptoms is diarrhea, weight loss, anemia, dehydration, abdominal pain, fever. There's usually 3 to 4 semi-solid stools with mucus, pus, or fat. The bowel movements can be bulky, greasy, and very foul smelling. The color and consistency of the bowel movements is like oatmeal. They might have right lower quadrant pain, a tender mass that's palpated, anorexia, or weakness. Complications is a malabsorption of vitamin B12, other fat-soluble vitamins, iron, sodium, potassium, acid-base imbalances. They can form fistulas. They can have other anemias. It can lead to hemorrhage or perforation. They can have abscess formations, toxic megacolon. They are more at risk for malabsorption versus ulcerative colitis due to the small intestine involvement. They can also have an obstruction, a bowel obstruction. It can lead to malignancies and osteoporosis. Diagnosis is done by colonoscopy, which is the most diagnostic. Treatment is, the drug therapy is the same as ulcerative colitis. And then they add on fish oil, which contains the fatty acids that have an anti-inflammatory effect. And they may need vitamin B12 and iron. In severe cases, they're going to have the TPN, maybe tube feedings, and then you're going to need to push fluids like 2,500 milliliters per day and monitor their weight, because they tend to lose a lot more weight than patients with ulcerative colitis. They might have surgery done to bypass or resect that involved or diseased bowel, and they might end up with an ostomy depending on the extent of involvement. And it's not, since it's an alternating with diseased and healthy bowel, I can't say that they're going to have an ileostomy or a colostomy. It just depends on which part of the bowel is the most diseased. So I just simply say ostomy depending on their extent of involvement and where it is in the bowel. Priority nursing care is teaching, monitoring their intake and output, and caloric intake, because again, remember, they're losing weight, so they need to increase their calories. Monitor their weight daily. A similar teaching to ulcerative colitis, assess their coping skills as well. These are just some images that compare ulcerative colitis and Crohn's, just to make it a little bit more clear. So ulcerative colitis, it progresses in a continuous fashion, which is shown in the image to the right, but it's on the left side of that image to the right. And then Crohn's progresses in an irregular segmental fashion, which is on the right side of that right picture. The left photo shows the differences in mucosa. So Crohn's patients are more at risk for malnourishment due to the small intestine involvement compared to ulcerative colitis. Diverticular disease includes diverticulosis and diverticulitis. Diverticulosis is a dilation or outpouching of mucosa through the smooth muscle of the intestinal wall, and it's most commonly found in the sigmoid colon. And then diverticulitis is an inflammation of those outpouchings from diverticulosis, which is only happens in exacerbation. So patients live with diverticulosis without any issues, and then when they develop diverticulitis, which is an acute temporary exacerbation, they're going to have severe pain and symptoms during that time. So causes of diverticular disease is a lack of dietary fiber, an increase in refined carbohydrates, and a decrease in collagen that's due to aging. Signs and symptoms, like I said, diverticulosis can be asymptomatic, or they can have mild left lower quadrant pain. Diverticulitis is a severe left lower quadrant pain, fever, increased white blood cells, gas, bloody stool, nausea, diarrhea, and distension. Diagnosis of diverticular disease is done by a barium enema or a colonoscopy, but only if they're not in the acute diverticulitis stage. So when they're in diverticulitis, they want to treat that before they introduce anything into the bowel. They might also have a CBC done, a urinalysis, and a stool for occult blood. I'm not going to go into the barium enema because we already discussed this earlier, but just know that they cannot perform this if they're having that diverticulitis flare-up. And then the colonoscopy, again, I discussed that earlier, And again, you cannot perform it if they're having a diverticulitis flare-up. Treatment of diverticulitis, the goal is to allow the colon to rest and repair. So they're going to be NPO, they might be on bed rest, they're going to have IV hydration. There's a possibility that they'll have an NG tube, and then they're going to monitor the labs to make sure that their hydration and electrolytes are in check. Sometimes surgery is necessary if they're having frequent flare-ups, and they might have a temporary colostomy just until that diseased bowel is removed, and then they attach the healthy bowel segments together. That needs to rest until they can have the colostomy reversed. Priority nursing care is progressing their diet as tolerated when ordered. So after the doctor feels like their bowel has rested long enough, he'll put diet orders in, and then you'll want to advance that as tolerated. Ambulation, pain medications, they're going to be in extreme pain. Teach a high fiber diet when they're not in diverticulitis. So fresh fruits and veggies, low fat. Teach to decrease their amount of red meat, and teach them to lose weight. Next, we're going to talk about miscellaneous intestinal and GI tract problems. So pinworms are enterobiasis that are small thread-like worms. It's the most common helminthic infection in the US, which is meaning parasite. Eggs survive for 2 to 3 weeks on surfaces. It's most common in preschool to school-age children. Causes is the fecal-oral route. They're discharged in the feces and then picked up on the hands and then put in the mouth. Signs and symptoms are intense anal itching, especially at night. The child might be irritable, bedwetting when they weren't previously bedwetting, and then they can't sleep. The pinworm cycle usually starts when they enter the body, when the child is exposed to the contaminated air, food, water, objects, and then the eggs develop in the stomach and duodenum. When the worms are in the adult stage, they move to the cecum and appendix, and the females move to the anal or perianal regions and deposit eggs, which cause the itching. The ingestion of the eggs to symptoms is usually 1 to 2 months. Diagnosis is done by applying cellophane tape to the anus at night and removing it in the morning. And this usually requires 3 applications, and then the parent should take that to the healthcare provider to view under the microscope. Alternatively, they can get a stool sample for ova and parasites. Treatment is Vermox or mebendazole, sorry, I can't talk, is the drug of choice. Anti-infective, a vermicidal or ovicidal. It's contraindicated in children under 2 years old and in pregnant women during the first trimester. They're usually chewable tablets that are 100 milligrams as a single dose, and it's repeated in 2 to 3 weeks. All members of the household should be treated regardless of getting diagnosed with pinworms. Priority nursing care is teaching good hand washing, and that itching may last up to 1 week after meds are started, and they can use creams like hydrocortisone creams in the meantime. Instruct to wash everything in hot water and dry everything in a hot dryer. Change the underwear frequently. Disinfect the toilet. Wash fruits and vegetables well. And they're going to need repeat testing to ensure that the treatment is effective. Hemorrhoids are unnaturally swollen or distended veins in the anorectal region. The veins involved in the development of hemorrhoids are a part of the normal structure of the anal region. Hemorrhoids can be internal or external, as you can see in the picture on the PowerPoint. Causes are straining during bowel movements, pregnancy, heart failure, prolonged sitting or standing, obesity, and weightlifting. Signs and symptoms are prolapsed tissue, so they can either feel or see a prolapse of tissue, pain or pressure, bright red bleeding with bowel movements, and itching. Treatment, most of the time it's conservative, so giving them sitz baths, analgesic creams or pads with lidocaine, topical creams with hydrocortisone to decrease the inflammation, stool softeners to make sure that they're not straining with a bowel movement. They can do warmth or ice compresses to the area, and these interventions should relieve the worst symptoms in 3 to 5 days. But when they have a exacerbation or more pain, they might have to repeat these steps. If they're causing issues, they can have them surgically removed by rubber band ligation, so literally putting a rubber band around the hemorrhoid, and the hemorrhoid eventually loses blood flow and will die and fall off. Sclerotherapy, like we talked about with varicose veins. Cryotherapy, which is freezing to remove them. Laser excision or infrared photocoagulation. But the most common is just a hemorrhoidectomy, which is simply just removing the hemorrhoids by an incision. They will need pre- and post-op stool softeners because you don't want them straining after the surgery. Priority nursing care, if the patient did have a hemorrhoid surgery, you need to be with the patient during their first bowel movement to prevent them from passing out. Because they're going to be in a lot of pain, and they're going to possibly trigger that vagal, they're going to possibly stimulate that vagus nerve, and it can lead to syncope. So you need to be with them their first bowel movement, because if they start to feel lightheaded, you need to lower them to the ground before they pass out. So be with them their first bowel movement. They also might have urinary retention post-op, so monitor their urinary output. If they haven't voided in 6 to 8 hours after surgery, you need to do a bladder scan, palpate their abdomen to make sure their bladder's not distended. Ask them if they feel the urge to urinate. They're going to need analgesics. Teach them not to strain during bowel movements, and it helps by giving them stool softeners or laxatives. Teach them to decrease weight and increase fiber and fluids. So colic happens in babies. It's caused by various things. They're not exactly sure of the exact reason, but the possibilities include allergies, cow's milk intolerance, maternal anxiety, family stress, and too rapid of feeding or overfeeding. It's likely that more than one factor is involved in colic, and it's more common in infants with sensitive temperaments who seem to need an increase in attention. So the infant tolerates formula or breast milk, they eat well, they gain weight, and they thrive with no changes in stool. This is unlike pyloric stenosis. So there seems to be there's no issue as far as the GI tract is concerned, but that the child is just increasingly fussy and irritable after eating. But they eat well, they gain weight, and they thrive. Again, causes are unknown, but it can be allergy related. Usually you'll see colic in 3-month-olds and less. Signs and symptoms, they are crying a lot. They're pulling the legs up to their belly, clenching their fists. They have a tense abdomen. They look flushed. They're unable to be soothed. They may have an increase in gas. Treatment can include antihistamines, antispasmodics, and antiflatulents. One of the most difficult issues is the frustration of the parents who are trying to cope with a new baby, and then that new baby is unable to be soothed, and they feel like they've failed as a parent. So teaching them that it's not caused by them. They need to remain calm, because the more they get frustrated and anxious, the more the baby is going to get frustrated and anxious. Teaching them that it's going to pass, and the baby won't have colic its whole life. Priority nursing care is getting a history of daily events from the parents, teaching them smaller, more frequent feedings, try a different nipple or pacifier that slows down the flow, reposition them frequently, invest in a swing that kind of helps to soothe the infant a little bit better. A lactose intolerance is a lack of or deficiency in the lactase enzyme. Causes are hereditary or acquired. It can be due to Crohn's or ulcerative colitis as well. Those at risk are African Americans, Native Americans, and Mexican Americans. Signs and symptoms are abdominal distension, cramping, gurgling, foul-smelling gas, nausea, diarrhea, and all of these signs and symptoms are linked to lactose ingestion. The signs and symptoms occur about a half hour to several hours after ingesting a milk product. Diagnosis includes a lactose intolerance test, so they're given 50 grams of lactose by mouth. Their blood is drawn before, and then at 15 minutes, 30 minutes, 60 minutes, and 90 minutes after. And then the failure of the blood sugar level to rise indicates a lactase deficiency. High lactose food should be avoided, obviously. Fermented milk products might be tolerated better, so cultured buttermilk, yogurt, sour cream. Sometimes if they have a very mild lactose intolerance, they can tolerate these type of milk products. Priority nursing care is just assisting the patient in finding lactose alternatives. Celiac disease is an autoimmune response in people who cannot tolerate gluten, which is a type of protein in certain grains. Signs and symptoms are diarrhea, cramping, abdominal pain, and distension after ingesting any type of gluten. Other signs and symptoms are variable and they can range in severity, so like bloating, diarrhea, and weight loss are common in many people with celiac disease. How celiac disease affects the gut is that the body's immune system attacks the gluten proteins and destroys the intestinal villi in the process. It causes inflammation and can lead to scarring and malignant cells if it's constantly exposed to inflammation. It can also lead to vitamin B12 and other nutritional deficiencies. Treatment is generally centered around having the client avoid foods with gluten in them. Teaching about label reading is key to helping these clients. Anything with oats, barley, soy, grains can contain gluten. They need to read labels because many things have gluten that they may not suspect. And they may also need vitamin B12 supplements. Nursing care would be assisting them in reading labels and figuring out the things that that contain gluten and the types of words that mean gluten, and then teaching them alternatives to gluten, because they're not going to be able to eat normal things like bread. They're going to need a gluten alternative to bread. So lead poisoning is just what it says. It's a poisoning with lead in the body. It's caused by ingesting lead paint or lead dust. Sources can include lead-based paint, caulking chips, lead-contaminated soil, dust. Drinking water can have lead if you have lead pipes. Ingested lead is excreted by the GI and GU tract, or it's stored in the bones. When ingested levels exceed the amount that the body can absorb into the bones, the lead travels through the circulatory system, and then it can be picked up by a lab test. So the lab test is simply a blood lead level, and if it's positive, if it's greater than 10 milligrams per deciliter. Signs and symptoms, it affects the neurological system, but it can affect the gut. So you'll see ADHD, hyperactivity, myalgias, abdominal pain, weight loss, encephalopathy, neuropathy, diarrhea, anorexia, pica, so they want to eat dirt or they want to eat laundry detergent because they're lacking minerals. They can have a metallic taste in their mouth. You might see blue gums, delayed development, and anemia because lead interferes with the synthesis of heme on the hemoglobin. Tests include urinalysis, abdominal x-ray. A bone x-ray will show lead lines in the bones. And then again, that blood lead level is greater than 10 for the diagnosis. Treatment is to remove the lead in the home and prevent exposure. And then chelation therapy is the removal of lead by drugs that are used to bind with lead. And it's the only therapy for lead poisoning. Priority nursing care is teaching prevention and doing an environmental assessment. Hand washing, wash the face, have a diet high in iron, calcium, protein, and zinc. So GI bleeding, this might not be in your notes, but it's good to distinguish the difference between upper and lower GI bleeding. The picture to the left shows various causes of upper and lower GI bleeding. So upper GI bleeding can come from the esophagus, the stomach, or duodenum, and it's most often due to a bleeding varices or an ulcer. And the patient will demonstrate hematemesis, which is blood in the vomit, or melena, which is dark red or black tarry stools. The blood in the vomit can manifest as like coffee ground vomit, so it looks like they vomited coffee grounds. A lower GI bleed comes from the lower small intestine or the colon. And it's most often due to Crohn's, UC, ruptured diverticulum, cancer, or hemorrhoids. And they will have the signs and symptoms of bright red or brick red bowel movements. So complications includes hypovolemic shock because they're losing their blood volume into their intestines. Treatment depends on the cause. They will likely have an EGD or colonoscopy to find and possibly fix the bleed. If they can't fix the bleed during the EGD or colonoscopy, it will require surgery or an arterial embolization, so clotting off that artery that's bleeding. And that's kind of like we talked about with the cardiac system with the cardiac cath. They'll go up through the groin and up into the intestinal arteries and embolize them. Nursing care is monitoring vital signs and intake and output frequently. They're going to probably be NPO. You're going to monitor for signs and symptoms of hypovolemic shock, and they will most likely require a blood transfusion. If they've had surgery or procedure like the EGD or colonoscopy, they're going to need the pre and post-op care. Dumping syndrome, again, this is not in your notes, but it's important to know. Dumping syndrome can happen after gastric surgery, and it results from the rapid emptying of food contents into the small intestines. There's a difference between early signs and symptoms and late signs and symptoms. So early happens within 30 minutes of eating. They can have vertigo, tachycardia, syncope, sweating, paleness, palpitations, and a desire to lie down. Late signs and symptoms occur 90 minutes to 3 hours after eating, and the major sign and symptom is hypoglycemia. So this is due to a release of an excessive amount of insulin. The high insulin results due to a rapid rise in the blood glucose that results from the rapid entry of the high-carb foods into the jejunum. So hypoglycemia signs and symptoms include dizziness, lightheadedness, palpitations, diaphoresis, confusion. Treatment is diet changes. They can also have a medication called octreotide or sandostatin, which is given sub-Q 2 to 3 times per day, and it's 30 minutes before meals, and this is only in severe cases. This decreases gastric and intestinal hormone secretion, and it slows stomach and intestinal transit time. Nursing care and teaching is teaching them to eat 6 small meals a day and to avoid fluids during the meal. By drinking during the meal, they're going to add to the volume that's in their stomach, and their signs and symptoms will be worse. So avoid fluids during a meal and eat 6 small meals a day. Unlike the other disorders that we talked about, these patients are going to recline or lie down for 1 hour after meals. So recline or lie down for 1 hour after meals. Their diet should include high protein, high fat, and low to moderate carbohydrate diet.